revive after.
Computer science classes.
It makes sense. It takes a while to adjust. Yeah.
And they actually tested the results of their students.
Adjusted yet.
Evaluations of
seen that
students on whether or not they taught NumPy first. And they said the students that were taught NumPy first, they used it throughout the rest of the course. Actually showed better and more thorough improvement of basic data science skills than others. I think it's because NumPy is just so ubiquitous now. It's hard to find an example that doesn't. Well, because
It depends if you're teaching.
ASHG is good.
All right, so we're going to go ahead and get started. Welcome everyone to the Tools and Technology Seminar Series. I'm going to pass around the sign-in sheet in a minute. As always, please sign in to help justify the pizza. So today's speaker is Amanda Kogowski, and she is the project manager for the System for Opioid Overdose Surveillance in Emergency Medicine.
Great. Well, thank you for the opportunity to present today. My name is Amanda Kogowski. I am a project manager at the University of Michigan, and I have been involved in this project for over 2 years now. So I'll just start off by giving this disclosure. This project is funded by the CDC-funded University of Michigan Injury Prevention Center, the Office of National Drug Control Policy, and the Michigan Department of Health and Human Services. So starting off with some background, this country is in the midst of a very large opioid epidemic. In 2016, opioids killed more than 42,000 people in the United States. Preliminary numbers from the CDC for 2017 surpass this. Every day, over 1,000 people are treated in emergency departments across the country for misusing prescription opioids. And 3 out of 4 new heroin users report abusing prescription opioids prior to using heroin. So that's just kind of a national picture. Now moving to, more granular into the Michigan opioid epidemic. In 2016, almost 1,700 people died of an overdose involving an opioid. From 2014 to 2015, there was a 13% increase in drug overdose death rates, and opioid-related deaths now exceed deaths from traffic crashes or gun fatalities. So all of this being said, surveillance is a very important part of the opioid epidemic. So accurate and timely surveillance can help inform interventions and allow all the stakeholders to see where resources are needed. So surveillance really varies across the country drastically based on state, resources, things like that. But just here are some state of surveillance across the country. So there are some individual county health departments that have opioid surveillance. This may not be scalable or sustainable. A lot of overdose fatal and non-fatal data is outdated or manually collected. Now, if this is a static epidemic where things remain the same, that would be all right, but we can't really assume that in this case. Naloxone administration, which is the opioid overdose reversal drug, is sometimes used as an opioid overdose indicator, and this may overcount overdoses, as naloxone is frequently given to all unresponsive patients in the field. Lastly, syndromic surveillance, which is based on emergency department chief complaint, is sometimes used as a surveillance tool. This measure is not as valid as the ICD-10 medical diagnosis code. So in Michigan specifically, I'll start by saying that Michigan is not unique in this way. A lot of states have these similar challenges. So emergency medical surveillance, EMS, naloxone surveillance can be obtained through the database MyEMSIS, and that is a statewide database. Emergency department is not centralized and is not currently tracked, and medical examiner data is also not centralized, and current fatal overdose data lags 18 months. So we are set out to improve surveillance in first Washtenaw County and then statewide is our ultimate goal. We have partnered with HIDTA, High Intensity Drug Trafficking Area, as part of a program called the Opioid Response Strategy. So I'm going to start by just giving some background on HIDTA, as a lot of people probably are not familiar with the organization. So they are a coalition of federal, state, local, and tribal law enforcement agencies that work together to work on specific drug control issues in their region. And they are a program of the federal government. They have no law enforcement authority. So in 2015, 5 HIDTAs came together at their annual meeting, and we're really talking about how public safety, public health collaboration is so essential in this epidemic and how everyone needs to be working together to really combat this epidemic. And from that one meeting, they developed the Opioid Response Strategy, which really focuses on connecting public health and public safety agencies in the 22 heroin response strategy states. I apologize for that. They just changed their name from heroin response strategy to opioid response strategy. So that's why it says HRS out there. So the University of Michigan Injury Prevention Center is playing that public health role in the Michigan Opioid Response Strategy project. So the ultimate goal is to improve collaboration between public health and public safety, increase timeliness and quality of overdose reporting, and develop strategies to reduce fatal and non-fatal overdoses. So through this partnership with the Michigan HIDTA, we started off picturing what our ideal surveillance system would look like for opioid overdoses. And we decided upon these 3 areas. So one, that's scalable, by using the minimum number of data sets necessary to obtain the most relevant data. We didn't just want to do this surveillance project in Washtenaw. Our goal was, and still is, to make this a statewide system. Maximize limited resources by identifying hotspots of both fatal and non-fatal overdoses. And then lastly, timely and accurate by providing opioid overdose data that is not under or overcounted. So as I mentioned, we started in Washtenaw County. We linked these 3 data sets of Huron Valley Ambulance Naloxone Administration data, ICD-10 codes of opioid overdoses from the 2 main emergency departments, Michigan Medicine and St. Joseph Mercy Health, and medical examiner fatal overdose data from the Washtenaw County Medical Examiner. Now, these 3 data sets were linked through probabilistic matching to avoid over or undercounting opioid overdoses. So what I mean by that is if a patient is transported through Huron Valley Ambulance, given naloxone, they enter the emergency department, receive the ICD-10 code, and then they end up on the medical examiner's table, if these were not linked, this would be counted as 3 overdose events. Linking the data sets solves that problem. So I'm now going to share some of our preliminary maps. So these are non-fatal locations of opioid overdoses from January 1st, 2017 through the end of the year, December 31st. The blue represents the resident location, and then green is incident. And then we have hotspots in 48110, zip codes 48109, 48104, and 48198. And then we have the fatal locations. Similarly, red is incident, blue is resident location, and hotspots are found in 48109, 48104, and 48198. So, as I've mentioned, we did the Washtenaw County pilot as a feasibility, testing it out, see how practical it is, and then this whole time we were strategizing how can we quickly expand this to other counties in the state of Michigan that is a more efficient way, as opposed to going to each hospital and getting IRBs, reaching out to each individual medical examiner, things like that. So this whole pilot, we've been strategizing how to quickly expand. And we found some sources that we are now using to expand the project. So as I previously mentioned, the MyAMSIS database does track naloxone administration for the state. Great Lakes Health Connect is a health information exchange company in the state of Michigan. They have access to over 80% of emergency departments in the state. They do not have health systems in the Upper Peninsula. So that is something that we're working to figure out how to get those health systems in the Upper Peninsula. And then lastly, there is an electronic death database called MDI Log, and approximately 50% of medical examiners in the state participate in MDI Log. So we will be using these three sources to expand. So, yes?
This actually goes hand in hand with a lot of my volunteer work. My wife is staff for the Jackson City Police Department, so I do a lot of their crime stats for them as a volunteer. And we did this just recently looking at opioid overdoses there, and there was this huge disconnect between when firefighters are reporting certain things, they don't ever, they have the option to skip certain drop-down menus in their reporting to say if this was an overdose or whatever it was, or they can just skip things altogether. We get a lot of headbutting with the hospital there about HIPAA and all this other stuff and what we're allowed to have as far as stats are concerned. And as a medical examiner, almost everything we got from the medical examiner was handwritten. I don't think they ever used MDI Log at all. And this is just the cops using, there's a whole lot of issues ever since the recent legislation that has made overdosing not particularly a crime anymore. So there's not a whole lot of crime reporting regarding that. That's almost a completely non-existent data source anymore because of that crime reporting. But all that in mind, these cops were able to get really super actionable intel without tremendous amounts of man hours trying to compile all this information. Now, I know Washtenaw is a little bit more forward-thinking, but when you start working with like the Jonesville area or Jackson or anywhere up north, you're going to start coming into these problems. How do you guys plan to mitigate that?
Yeah, and that, you bring up great points, and we have certainly already experienced those things. So in regards to the electronic death database, you're right. There are 50% of counties that do not use MDI Log. They may use access databases or their own homegrown, or they may use paper records. And that is something that our state partners have told us they are still driving around county to county collecting this overdose data. So that's something we've definitely been strategizing how to overcome those barriers. To start, we are working with the MDI Log counties. Our kind of thinking behind that was the more counties that are participating and that we can show, like, this is what we're doing, these are the positive results, we'll get other, potentially more difficult counties to kind of buy in that way. But it's definitely something that we've had lengthy discussions on, how to incentivize medical examiners to participate in MDI Log. Are there resources that we can help them with to do this? That's definitely something, we're actively working on. And then in regards to the EMS data, how you were saying it's so hard for law enforcement to get that actionable intelligence, that's something we really, now again, patient privacy is our #1 concern at all times. We do not ever share any PHI or exact locations on a map with our law enforcement partners. But that is for sure the most important priority for us. We also know that by census tract or basic demographic information of the people that are overdosing is valuable information to them. Does that answer your question?
Yeah, I was just noting that there's tremendous difficulties.
Yes.
And you're seeing it.
It's been a long road, but it's exciting. And then something I think that everyone will be really interested here is we are creating, or we have created, a S.O.S interface. So the ultimate goal is to have a real-time dashboard where stakeholders can log in and see, okay, there were 10 overdoses in this census tract last night. And then they can, inform interventions based on that. So this was our preliminary prototype S.O.S interface that was created about a year ago now. This is just the About page. Then here's an example of the county level map. Now this information will be available to the public. Nothing more granular than this will be available to the general public. And then we have this census tract map that if you're a participating hospital or an ME or EMS can log in to see in real time where the problem areas are located. And then we also will be doing some different geospatial analytics. We'll have heat maps, other things like that. And then we'll have aggregate demographic information, gender, race, age. So kind of diving into more of the details. The S.O.S interface in this upcoming year, non-fatal overdoses will be updated 3 times a week through EMS. And again, that's the naloxone administration. The ED data will be real-time, every 24 hours. And then fatal overdoses, we will get suspected overdoses within 24 hours. And now by suspected, that could be paraphernalia on the scene, witnesses, things like that. And then 3 weeks to 90 days later, we'll get confirmation or the opposite from the toxicology reports. So we'll have the suspected be one color, and then once it's confirmed, it'll change and go to another color. As I previously mentioned, there will be a linkage of the 3 data sets, which eliminates the overcounting or undercounting of opioid overdoses. We'll have both rates and raw numbers. Our public safety partners are really interested in the raw numbers, whereas us on the public health side, we find the rates to be more beneficial. This will provide both location of home and location of death from the medical examiner data. And for non-fatal EMS, we'll have both home and incident location. And this allows for tracking of movement. We've been talking a lot about overlaying different maps with buildings, highways, so example 94, things like that, just for everyone to be able to have a better picture. As I mentioned, the county level data is available to the public, and the census tract data will be password protected. Yes.
Why is county the most granular for public?
And we've had a lot of discussions around this, and based on our IRB and everything, we are able to share census tract, but we kind of just decided we didn't think the general public needed more granular information than that, and what would they be doing with that? Something that from the beginning to now, we're very, very sensitive about keeping everything as bird's eye view as we can, just because of the sensitive nature, and we haven't really thought of a good enough reason to give the general public more access than that. Yes.
So you tend to show location of home and location of death or overdose incident. Do most people overdose near their home?
So our law enforcement partners have told us that people typically overdose within a mile of where they purchased their drug. This doesn't necessarily seem to be the case in Washtenaw County, and that may just be the demographics of Washtenaw compared to other areas in Michigan. So then the next steps, we will continue expanding the surveillance to the other 9 high-intensity drug trafficking counties. There are 12 total in Michigan. Washtenaw County is one of them. And we have the ultimate goal of statewide surveillance in the next 3 years. So final implications, S.O.S. allows both public health and public safety to continuously follow the size, spread, and trends of both non-fatal and fatal overdoses. It allows us to implement interventions in communities where they are most needed and informs allocation of resources. And some exciting news, we recently received some funding to use S.O.S. in Washtenaw County as a case use. So we'll be reaching out to on-the-ground stakeholders to see how they can use the S.O.S. maps and inform interventions. Any questions?
I'm wondering how often the hotspots change. Because you're very concerned about tracking in a timely fashion very quickly overnight. Is that in order to track new sources coming in, or is that because the hotspots are changing?
So again, in Washtenaw County, the hotspots were pretty static. But if you go to other areas, larger cities in the state, something that could happen, and what other people are doing. If there's a spike in this census tract yesterday, okay, let's deploy naloxone to that area. Let's increase interventions, boots on the ground. Let's, have increased outreach over there. So that's really the main goal, is to inform interventions from the hotspots and spikes. Any other questions?
There's also, just go back to the maps.
Yeah.
Yeah.
Oh.
That one. So in particular, really what you're seeing here is population density.
Yeah, so this map, our developers told us, don't really read into it. It's an example of what we can.
Okay.
And it's not fully developed. Because yes, you're right. And that was a huge thing with our, with all of these. This is population density. But our public safety partners will always be interested in this, and then we'll be adding rates to the interface in this next year to give us a better picture of things.
So how many people here are part of the team to develop the S.O.S.?
So we have, you mean at the university? Yeah, so there are 5 or 6 co-investigators, and then we have the principal investigator, my supervisor, Dr. Mashida Beer, and then we have a team at University of Michigan Transportation Research Institute, and they are doing the development of the interface. So there are probably 6 of them. So we have a good team.
Now, again, I keep on going back to what I've done. Because of the access that I had to certain information, victims, perpetrators, and stuff like that, I wanted to anonymize that data for the cops so that they're not, because if you look back at one of your first maps to the overdose, it was a scatter plot, that one. That's a lot of information that at this bird's eye view is hard for a cop on the ground to find good resolution as to what's going on. So to remove those spots, to give them a little bit more visibility, I split that all up into like a hex bin and then counted the points based off of hex bin densities. So the darker the color the hex bin is, the more incidents of a specific type were in that. And this allows cops to see, or this allowed cops to see specific spots within the city, like neighborhood specific spots within the city that have a high propensity for these types of related actions, either aggravated assault or drug use. But it's completely anonymized. We don't have subject address, we don't have subject name or anything, just counts. Is that kind of data possible to provide to the public when there's absolutely no address information or patient information involved in it?
Yeah, we'd certainly have to talk about that, and we haven't. I would love to chat further with you and see if I can see some of those examples. That sounds like really beneficial, but that hasn't really been something we've really dived into.
For example, when I moved to Ann Arbor, I found the crime maps very useful because you could see very quickly, here's where all the cars are being stolen. And something like that would, again, I think, be useful to the public in just coming to Michigan.
And that's what I keep thinking, exactly, is when we moved here from North Carolina, we looked at sites like, North Carolina has a site called Be the Badge, but it's the same concept. You look at these crime maps. Where in the city am I going to live that I'm less likely to be part of this specific crime? Or say you're somebody that's moving to a new city, but you have a history of drug use, you're trying to stay away from it. Identify portions of the city where you're less likely to have that intersection, that kind of stuff. That would be very helpful.
Yeah, those are really good points. And down the line, that may be something we do. Something that I don't think I've mentioned is how difficult it is to get health systems to buy into this. They need to agree to participate in this. So they're giving us their patient data. Very sensitive. So right now, something too is we've told them all, public will not be looking and seeing your patients where they're overdosing, things like that. Now again, you mentioned a lot of masking things that we could do, and down the road, I don't see why we couldn't do that. But for right now, and while we're still in the phase of getting buy-in from health systems, getting buy-in from MEs and all these stakeholders, we've really decided to make it as protected as possible, more than we even have to, based on our IRB and agreements.
I think that's great that you're taking that route. I can see where this information could be misused, even if it's allowed to be poured out.
Right, and that's something too. While we were manually doing these maps, we were only sharing them once we reached a threshold of 10 overdoses per county. Just because, again, we need to keep this de-identified, which is, it could be a month, and that's as real time as we could make it in the pilot, but we, feel it's very important to keep that information completely anonymous and de-identified.
Yeah, you talked about all of the challenges and all this, but you've got a 3-year plan for extending this out to the rest of the state, and I think you said there are 12 counties you're currently working with that participate in that acronym program. So are there additional challenges in moving out to the counties that don't participate in that program? And what are they? And how are you going to deal with that in the 3 years?
So a huge thing is we have not written a grant for this project at all. We've just gotten funding from the 3 sources I listed. So a huge thing is resources. We are actively applying for funding. Challenges besides that really is getting everyone to sign the agreements.
Is that something that group kind of facilitates for you in the 12 counties? Oh.
We do that. So our partners, let me go to, wrong way. So our partners, Great Lakes Health Connect, they have the partnerships with the emergency departments. And, we've been finding a lot of emergency departments or health systems love the project, think it's a great idea, but they're not prioritizing it in the timeliness that we would like them to, because they're massive health systems. So that is a challenge that we're currently facing. And then, as you mentioned, not everywhere uses these databases. So again, the statewide MyEMSIS EMS, we're good there. I mean, there's going to be, data quality and things that we'll definitely have to cross when we get there. But as far as the buy-in goes, Great Lakes Health Connect does not have anything in the Upper Peninsula. So, and that's a huge area that, really needs to be addressed. So there are other health information exchange companies up there that we are working to reach out to and see if they can participate in a similar manner to Great Lakes Health Connect. So Great Lakes Health Connect is actually our initial contact with all the health systems. And then we have a call or a meeting with the health systems, tell them more about the project. And then also MDI log, the medical examiner piece. For the 50% of the counties that do participate in MDI log, we have a great point of contact through our partner to reach out to the MEs. He already has an established relationship with them. With the ones that don't participate in MDI log, we'll have to be reaching out one by one, telling them the benefits, and something too, medical examiners are incredibly overworked with the opioid because of the opioid epidemic right now. Everyone wants their data. And, you know, depending on the county, some medical examiners are more willing to participate than others. So a huge, huge part of, you know, our team's time is reaching out to these groups and having meetings and obtaining buy-in and consensus.
Any advantage, I know some groups work with insurance data. Is there any advantage for you to look at some of that if you can access it?
So again, in the future, yes. Right now, our main, in MAPS data as well, there are a lot of things that we would love to include. For now, just to, you know, get this up in a timely fashion to get everyone to participate as quickly as possible, we decided to focus on these 3 main data sets that we think most accurately show simply overdoses. And, you know, there's a lot that we could do in the future. Another thing I don't think I've really touched on is we cannot use this data for research. This is strictly public health surveillance. And this is a actual law for health information exchange data. And we've also just decided internally that using it for research would probably cause some concern for some of the people stakeholders we're trying to get buy-in from, and strictly public health surveillance is a better way to get the system up and running and expanded.
Are you guys reaching out to politicians at all? Is it a political thing now?
Not right now, no, we're not. Again, something to think about. I mean, we've had some talks, but no, we haven't done anything.
Any other questions?
Great, well, thank you.